If you have questions that you would like to ask the presenters, please put that in the question and answer box. To find the chat box in the question and answer box, just go down to the bottom of your screen. If you're looking on a laptop or desktop computer, you'll see the chat and Q&A buttons there. We do have a certificate of attendance available for you. About halfway through, we will put a link in the chat box. Robin will put a link in the chat box there, and you click on that link, fill out the form, and it will send you the certificate in your email to your email. And just a quick note of an upcoming presentation on December the 5th, we have our Research Spotlight webinar, and we have Dr. Stephanie Glegg and Dr. Nadia Fairbairn from the BCCSU coming to talk about their work that they've published in an article called COVID Just Kind of Opened a Can of Whoop-Ass. So I invite you all to attend that. The link to register for that is on our website. And again, check out our website for more information. So with that, I'm really happy to pass this over to Chris. Chris, I'll let you introduce our presenters today. I'm just really grateful for everybody being here today to talk about mobile safer supply programs. For me, I was really excited about this because safer supply programs do aim to meet the needs of people who use drugs, who are often very disconnected from healthcare and social services. And so, what better way of meeting their needs by going to meet them where they are at, both geographically as well as in all the other ways. So, Chris, I turn it over to you.
Thank you, Rebecca. My name is Chris Shetty. I'm a clinical manager of addiction medicine and withdrawal at Stonehenge Therapeutic Community in Guelph. We have just started recently a rural safer supply program. So I'm happy to moderate today, and I'll be introducing the presenters. So mobile safer supply can look different and mean different things to different people. We have presenters here from different teams to share their experience. The presenters are from our teams from London and the Toronto CHCs. We will have Parkdale Queen West Community Health Centre, South Riverdale Community Health Centre, and our final presenters are from the London InterCommunity Health Centre's home team. So first we are going to start with Parkdale Queen West Community Health Centre, and speaking today from there is Hannah, Madison, Delana, and Pranitha. And you can take it away.
Well, good afternoon, everyone, and welcome to our presentation on our mobile safer opioid supply program at Parkdale Queen West Community Health Centre in Toronto. Today, we will be providing an overview of our mobile program. We will discuss some program demographics and early themes, successes, and challenges that have emerged thus far. Next slide, please. Thank you. In general, during the development and expansion of SOS programs, many systemic harms have surfaced. For example, attachment to safer supply is generally inaccessible due to the extremely limited capacity of programs. There are also a limited number of providers who deliver the service. We also know that barriers are increased when individuals are precariously housed or unhoused and struggle with the social determinants of health that impact their access to adequate care. Individuals in shelter settings experience greater fractures in healthcare due to rigid shelter rules and regulations and the frequency of discharges and restrictions in shelter spaces. Next slide, please.
Thank you, Delana. Now I'll talk a little bit about the mobile SOS program here at Parkdale Queen West. Initially, we thought we were the first mobile SOS program in the province, but that honor goes to the London InterCommunity Health Centre, who started their mobile program in 2020. At Parkdale Queen West, our mobile SOS program launched not too long ago in November 2021. So we are quite a new program in operation for 1 year. Our program consists of 2 NPs, myself and Delana, 1 registered nurse, Madison, and 1 case manager, Hannah. Being mobile, we provide our services in shelters, sheltering hotels, respites, and recovery sites. We also help our clients navigate the healthcare system and link them to wraparound services, such as case management and counseling support. Next slide, please. By meeting clients where they are at, our program aims to increase client retention in our SOS program and minimize the no-show rate, thereby ensuring client engagement. When clients are engaged with us, we are better able to support clients to achieve their goals, including decreasing or eliminating their use of toxic street opioids. By meeting clients where they are at, we hope to lessen the effects of a fractured healthcare that unhoused and precariously housed folks encounter. For example, a client may be receiving primary care and case management support through a sheltering hotel, but those services are abruptly stopped if the client were to be discharged from that site. Our program aims to honor continuity of health and supportive care regardless of a client's degree of migration. Next slide, please. Our program is a response to the urgent demand of people who use drugs for a safe alternative to the toxic street supply. We provide access to pharmaceutical opioids of known quality, quantity, and strength. In our program, this safer opioid is hydromorphone of 8 milligram tablet formulation. It is important to note that our program is absolutely not abstinence-based. We work with clients to achieve their goals, and if their goal is to reduce rather than eliminate their use of street opioids, then we will work with them to achieve that. This is in line with our philosophy to support clients to lead self-determined lives. Our team also provides education around harm reduction techniques, provides harm reduction supplies, and promote the use of supervised consumption sites. Next slide, please.
All right, so at Parkdale Queen West, we're really lucky to have an extended team who operate harm reduction services in a number of the shelter, respite, and shelter hotel settings, and that's contributed a lot to our success as we've developed a streamlined referral process with these partners. iFare and Launch, formerly known as MOVID staff, have access to a simplified referral form and have knowledge of program eligibility criteria. So they provide harm reduction supplies and education in a variety of these settings and are able to connect the interested and eligible folks to our program as appropriate. Historically, we've also had referrals from the COVID-19 recovery site and shelter operators who have reached out to establish referral pathways. Other clients have come to us through peer and self-referrals, as well as inter-team transfers from the fixed site teams who have indicated a preference for or whose needs are more able to be accommodated by the mobile team. And through all of these referral pathways, an ongoing relationship with the referring partner is super key to ensuring client success in the program because they're able to coordinate and facilitate appointment times, reminders, and spaces for clients to be seen at the different sites. Next slide, please. So once a referral is submitted to our team, one of the clinical staff will be assigned to complete a screener assessment of the person referred to ascertain their eligibility. The screener can be completed in person or via telephone and is facilitated by the referring party typically. Clients are screened for inclusion criteria, exclusion criteria, and complexity-related information to triage them. And then our team meets weekly during our open referral periods to discuss capacity, determine eligibility, and triage the eligible referrals. And all of the members of the team are involved in that process. Next slide, please. So once a client's been identified as eligible and an NP has capacity to take them on, I make their chart, complete an initial Connecting Ontario review, and alert the NPs to enter lab requisitions. And then I work with the referral source to schedule their initial nursing onboarding appointments, which can be from like 45 minutes to like an hour and a half in length, depending on client complexity and a number of other factors. That nursing intake, the first part involves collecting a detailed health history, including mental health, physical health, and substance use history. And that takes place like usually at the shelter site. So it's fun, you get to do it in like a little hotel room sometimes. The second part involves a comprehensive physical assessment, including collection of blood work and urine sample. And it also involves the assessment of vital signs, auscultation of heart and lung sounds, and specific physical assessment if triggered. And then finally, we collect the consents for collaboration with shelter staff and releases of information for obtaining collateral health information, provide the clients with contact info, troubleshooting pointers, and an opportunity to ask any questions that they may have about the program. And then following the nursing intake, I'll alert the team of any contraindications that have come up, corroborate the info on Connecting Ontario, and fill out the remainder of their chart. So once that's been completed, clients are scheduled for an intake with the NP when their blood work results are back, and a case management intake follows their NP intake. Largely similar to other things, just in a shelter. Next slide, please.
So for the case management intake, I meet with the client after they've connected with the nurse practitioner and completed the assessments with Madison. The case management intake is client-led and is geared towards what the client is looking to work on. I do have a list of points I address in the intake to get a sense of current supports the client has or areas where they may be looking to grow. Sometimes support can look like renewing ID, appointment accompaniments, or connection to legal representatives. And other times it can look like completing taxes and housing applications. Within the intake, I do ask questions that I've noticed can sometimes be overlooked, such as dental appointments, foot care, or hearing and eye appointments. Not everyone is looking for case management supports, but I do try to make an effort to connect with each client and extend the welcome to anyone who may be looking to expand their support network. Next slide, please. So to date, we've received 129 referrals across Toronto since November 2021. We do not have a catchment area within the city and therefore meet with clients at any shelter or respite they may be staying at. Currently, we have 50 clients enrolled in the mobile SOS program and have discharged 6. Of the 129 referrals, 4 clients were declined due to preference for opioid agonist therapy, and 6 clients were transferred to the base SOS teams after securing housing. We've had 18 clients ineligible for mobile due to meeting exclusionary criteria, and 19 clients weren't interested in staying on the program. We do our best to try and locate clients who have been referred and lost to follow-up, or sleeping rough, or sleeping at various friends' places, but we have had 24 clients who we've been unable to locate and see if SOS is still for them. Once a client is discharged and no longer has an active prescription, they can still receive 2 months of wraparound support, either with case management, counseling, or referrals to specific programs. Next slide, please. Amongst our 50 clients, 37 or 74% identify as men, 12 or 24% identify as women, and we have 1 client or 2% who identifies as non-binary, and a total of 4% of our clients identify as trans. Next slide, please. Oh, there we go. Yes, that's great, thank you. Within the 50 active clients, a total of 38 or 76% are white or non-BIPOC. 9 clients or 18% are Indigenous. 2 clients or 4% are Black, and we have 1 client or 2% who is a person of color. Next slide, please.
So data collection has allowed us to have a comprehensive qualitative picture of how the mobile approach to SOS is benefiting our clients. Our clients endorse reduced vent use, fewer overdoses and trips to the hospital in general, more and higher quality connections to primary and preventative healthcare, better connections with social support networks, and more money to be able to spend as they see fit. Clients also identify not being dope sick and having to rely less on illicit methods of obtaining substances as benefits as well. And poignantly, clients have identified being still alive as a major benefit of the mobile SOS program.
Even though our program is in its infancy, we have encountered our share of successes and challenges. Some successes include providing a low barrier model of care to clients by meeting the clients where they live and being as accessible as possible. Our clients know that they can call our team directly rather than going through the main switchboard, for example. We found that once the client has met every member of our team and has an active prescription, the retention and engagement rate is quite high. Beyond SOS, we connect clients to primary care, Hep C treatment, and wraparound services such as case management, counseling, and health navigation.
In terms of challenges, the first 2 points, working with shelter operators and promoting SOS as harm reduction, are somewhat related. We've encountered some challenges in terms of lack of knowledge around SOS as a harm reduction response to the ever-increasing toxic street supply crisis. It is important to note that we are not treating opioid use disorder, but rather reducing the harms associated with a toxic street supply, and we've had to educate some shelter operators about this. Furthermore, we found in some instances, shelter operators are not as client-centered as they should be. For example, clients will be discharged from a shelter hotel with little to no notice for minor infractions, and we've advocated as best as we can to have that client stay in the home they've known for the past several months or transfer to another location rather than be discharged onto the streets. And the last point, following clients after discharge from the shelter system, is something we are encountering more and more of, especially with the closure of the Esplanade Hotel and clients being told to vacate by no later than December 6th. To continue seeing clients, we've had to transition to providing care at our Queen West site. We have clinic space booked a couple of days per week, which has allowed us to continue providing care to clients no longer in the shelter system. This is an example of how we've had to adapt to changing scenarios to ensure continuity of care for our clients. Next slide, please.
Looking into the future, our mobile team will be offering hepatitis C management. We have found that many of our clients have hepatitis C. However, connecting the clients to Hep C programs has been challenging as the clients tend not to show up for these appointments. So we thought by offering Hep C treatment in-house and within the same SOS appointment, we would cut down on those barriers. In addition, our program is only a year old, so we would like to continue to collect data through questionnaires and chart reviews to evaluate the outcomes and client concerns to inform and shape our program.
For connecting with mobile teams, we've had an opportunity to mentor and learn from other mobile teams, such as the Mobile SOS program at South Riverdale CHC, who are here with us today, and the Inner City Health Associates, who have recently started their own mobile OAT and SOS program. We look forward to continue to work with these teams to learn from and support one another. For the Mobile Advisory Committee, base team clients at our organization have been involved with the advisory committee, where they share their thoughts, concerns, and recommendations on how to improve the SOS program based on their lived experience. As our program expands, we are aiming to include mobile SOS clients in the advisory committee as well. And for closing thoughts, we want to iterate that our program is an extension of harm reduction and not meant to be addiction treatment. We are not abstinence or recovery based. We prioritize the voices of people who use drugs. Our mobile SOS program is a response to the ever increasing toxic street supply and the need to provide low barrier care to address this crisis. And with that, that ends our presentation. Thank you.
Thank you very much. We're going to hold questions for this group until the end, but thank you for sharing your presentation. Next, we have individuals from South Riverdale Community Health Center. There's a few people from South. I don't know if they're all here though. So I'll get them to introduce themselves as they come on. So I think you guys are sharing your slides.
And I'm just also going to jump in and remind people to please speak slowly for our French interpreter team. Thank you. Sorry to interrupt.
I can kick us off. So I'm Jolene. I'm the program manager of the South Riverdale Safer Supply program at 955 Queen and also of the SOS Mobile, but I also oversee the programs at Street Health and Regent Park. I'll pass it to one of my other team members to intro. So we can just pass it around.
Hi everyone, my name is April. I'm a community health worker on the SOS Mobile team at South Riverdale, and I'll pass it off to Tanisha.
Hello everyone, my name is Tanisha and I'm another community health worker here at South Riverdale Community Health Center, and I will pass it to Naima.
Hi everyone, I'm Naima. I'm a nurse practitioner. I'm the only nurse practitioner right now on the Mobile SOS program. I'm happy to join everyone here today. I will pass it along to Adriana.
Hi everyone, I'm Adriana LeBlanc. I guess my title is a trauma social worker. So I'm one of the social workers here with the mobile team. And I will pass it over to Nikki.
Hi, I'm Nikki. I'm the other trauma social worker on the SOS Mobile team at South Riverdale, and I'm going to pass it over to Mel.
Hi, I'm Melanie. I'm the program support worker for SOS Mobile at South Riverdale.
Thank you. So we can skip ahead to the next slide. I just have to adjust. Okay, so just looking at an overview, in June 2021, SUAP provided an opportunity to amend our existing funding, looking at existing gaps in services identified by what is now the SOS 955 fixed site team. A decision was made to create a mobile SOS team that further serviced the geographic area east of South Riverdale CHC, which is 955 Queen. Given the lack of addiction services, the SOS 955 Fix Site team began operating in June of 2020. The gaps identified in the interdisciplinary team were trauma-based social workers, a program support worker, and a pharmacy consultation support, given the ongoing challenges that we have with pharmacies and medication formulary options. One of the main trends the 955 team had identified is once clients had stabilized on their SOS prescriptions, histories of complex trauma tended to surface. And there were significant challenges finding appropriate services for this need. Part of it, I think, was COVID related. And I think the other part of it is that they just do not exist. Those with living experience is something our team values. And in conjunction with our patient advisory boards. Next slide, please. So just a bit of a timeline. In March of 2022, South Riverdale CHC SOS mobile program started. So of the 3 presenters today, I believe that we are the baby of all 3 programs. There was a noticeable gap of addiction services available in the East End. So further east of South Riverdale, there's 1 hospital and there is maybe a handful of providers that are doing how to best serve a different community of substance users than the downtown services are tailored towards. Our amendment was approved in December of 2021, just days before Christmas. So it was a nice Christmas present. And South Riverdale began hiring for the mobile team in February of 2022. And we still remain hiring for a few positions, which we'll talk about. We're aiming to serve clients east of the center's main location at 955 Queen Street East. The mobile team operates a clinic out of 1245 Danforth Avenue, which is a temporary clinic location, and at multiple outreach locations. This includes working with existing resources in the East End and general street outreach as we continue to grow the program. And there's been some pretty extensive partnership developing and building as well that is coming into where we go and how we work in the community. Next slide.
So just a little bit about our staffing model currently. So our team has 2 registered nurses and 1 nurse practitioner. We have 2 community health workers, the 2 trauma social workers, and a program support worker and administrative support. Like Jolene mentioned, we are still currently hiring and recruiting for an additional nurse practitioner, 1 more trauma social worker, 1 more community health worker, and additional administrative support.
So Nikki and I will address this first point on trauma social workers. So this really came out of, as Jolene was mentioning, around the, really noticing that as we get to know clients, their histories of complex trauma tends to come out. So we're really, on the ground, been looking at how to sort of develop a program of social work and counseling support to help the clients. And as we're saying, like to meet them where they're at, like emotionally, not just like the physical piece. So one of the things, Nikki and I will talk to 2 different things, because the thing that has happened with me, I got hired first and I was already hired at South Riverdale. So I ended up providing quite a bit of coverage for the fixed site team. And so that's kind of become, I guess, one of my focuses. But then, and Nikki's been sort of like supporting the mobile team now. So I'll turn it over to her to talk a little bit more about that.
So yeah, being the dedicated social worker for the SOS mobile team, I only see our clients here. So that has given me freed up my time to be able to get to know people in like a more slow, organic, kind of natural way, because often people see the trauma, the T word in our title, and they're kind of like, no, I don't want to talk to this person. I'm just going to avoid, nope, thanks, see ya. So I've had the opportunity to slowly kind of build connections with people, and that has led to people slowly being more willing to kind of see me and to start talking to me and building a good therapeutic alliance. So that's kind of both me and Adriana's niches, and it seems to work pretty well for our folks. So.
Yeah, I will mention that so there's a lot of crisis support that we do with people. I do think it's very handy when we're on site, like people see us and they develop the relationships with us. As Nikki's been able to go out far more with the mobile team than I've been able to, and I guess unfortunately for me. But yeah, she's made some fantastic connections there. One thing I did want to just mention, though, is we have started offering some group support. So we started a drop-in group for our clients, and I guess it was in June. And essentially, this group sort of, it's anybody who's in the part of the Safer Supply programs, and we alternate 1 week where we do like sort of like a creative or arts-based kind of activity, and then we have the following week we have more like a psychoeducation, like some kind of mental health, trauma, or substance use topic. So these groups have been wonderfully attended, in our opinion, and it's really a great way also for us to build connections with people. And so, you know, some people who are a little bit afraid to speak with us once they've met us a few times at the group, then it doesn't seem quite so scary to connect with us. We're also, one of the things that our clients did identify, though, is that people with the drop-in group, people are at different stages in terms of what they're wanting to do, or what their goals are around their substance use. So people who did want to stop or reduce their street drug use were sometimes finding themselves triggered by other people who didn't have that as a goal. So what we're doing right now is looking into doing a seeking safety group for clients who are in that space. So we're still building up that group at this point in time and hoping to start it really, really soon. Anything else, Nikki, that you can think of?
No, I think you pretty much covered it.
Okay, I'm going to turn it over to Mel.
All right, so as the program support worker on the team, I organize the advisory board across the Downtown East collaborative sites, including the mobile team. I also help run our weekly drop-in for Safer Supply clients. Soon I will be helping with the Seeking Safety as well as cooking groups at South Riverdale. Finally, based on client feedback that I gained from doing advisory group, I helped plan a trip to Ripley's Aquarium with clients and staff across the Deck SOS, and we hope to do more trips like that soon. And next slide.
So this slide highlights some of the mobile clinics that we're currently running and the outreach that we're doing in the East End. So with the Aging Core Community Services Association, or AXA, we do a drop-in clinic at their South Drop-In Center. So this mobile clinic acts as a space for clients in Scarborough to have their regular appointments with us. We receive referrals through them, and it's been getting a lot busier, and it's a great drop-in space for our clients who are quite east to be able to kind of meet us halfway. We also previously had a mobile clinic at the New Hope Salvation Army Men's Shelter. It has since transitioned more into just providing harm reduction education and support through other teams at South Riverdale. We found that the mobile clinic wasn't super busy, but they were still interested in having more harm reduction supports in their shelter than they previously had. The Scarborough Center for Healthy Communities is a new partnership that we're just beginning. It's not listed on the slide, but as well, we are also partnering with the LEP program that they help run at 140 or 4175 and 4205 Lawrence East Avenue. As well as we started a new partnership with the Delta Shelter Hotel run by Homes First. And that's a mobile clinic that's been very busy because we just go right to where folks are living and do a drop-in clinic for them there.
Another piece that we're lucky to have is a consulting pharmacist. And so basically, this has been really helpful because there's a lot of issues that come up with pharmacies, and especially when we're prescribing these high doses of opiates, and pharmacies out east, they're not used to seeing that, right? The SOS programs that kind of exist, they've been more downtown, and then a couple of these pharmacies maybe they're on the like the methadone program, like they've been trained to dispense methadone, but they're still pretty new to the rest of the stuff. And so having the pharmacy consults has been really helpful, because then we can just go straight to an expert who knows about SOS and knows about pharmacy rules and regulations and what kind of standards they have for documentation and communication. And so he's able to kind of give us advice about, how to troubleshoot issues that we're having with pharmacies, and then also how to like best set up partnerships with these new pharmacies that we're approaching. And then also, if we have questions for the pharmacists that are related to medications, maybe related to people's abnormal liver or renal function, we'll kind of run things by the pharmacist if anything nuanced comes up. So it's really been a helpful addition.
I'm going to talk a little bit about the barriers that the fixed site team has identified and that we've also faced during our few months. So a lower retention of clients who are at risk of incarceration or struggling with longstanding trauma and mental health issues. When folks are incarcerated, it's a lot of navigating the release and trying to figure out how long their incarceration is going to be. Unfortunately, as you all know, the medication available is not great. The access that we have to the MSW trauma counselors now as well are helping with the trauma and mental health issues, but of course there's still limited access to psychiatric services. And of course we have only 2 MSW trauma counselors that cover our team and cover the fixed site team. So as we continue to grow our program and have more clients, they will have limited availability as well. Another challenge is limited Ontario Drug Benefit Formulary coverage. The medication that we have access to, of course, could be improved, and it would be better suited for our folks as well. The limited capacity for enrollment in the program due to hiring challenges. I think we'll discuss a little bit more of how many clients we have on our program later, but we only have 1 nurse practitioner, and there's only so many clients and patients that she can see and do prescriptions for. So if we had access to both of them, then we could double the amount of people we could take. Limited options for housing at this time. Many of our clients are currently houseless or sleeping outside. It's difficult to enter a shelter in Toronto, and of course, like the Parkdale Queen West team talked about, many of our clients are then discharged for minor infractions and trying to navigate those pieces in advocacy as well. And limited options for social engagement through any volunteering, peer work, drop-ins, food programs during COVID. Like Adriana was mentioning earlier, we do have our SOS drop-in program, which has been a great point of connection between our clients and between us as staff and our clients as well. But of course, there is still capacity in place on how many people we can have join the group on a weekly basis due to just the room size and COVID regulations. And it's difficult to conduct follow-up with clients who lack access to transportation, phones, or the internet. We're lucky to have access to phones through South Riverdale, but of course, phones are stolen, they get lost, and it's difficult to replace them. Even when we try to meet clients, who are staying outside and try to meet them halfway at their pharmacy or at a coffee shop, still difficult to connect with them to remind them of these, prearranged appointments. Luckily, we do have access to a driver as well who can take clients back and forth. And
So some of the successes that our program has had and some feedback that we've already received is that 88% of our clients have reported a reduction in fentanyl use. And as Parkdale Queen West mentioned, similar to our program, we're of course not a treatment program or abstinence-based, but a lot of our clients identified that reducing their fentanyl use is a goal of theirs. So we want to help them reach that goal if that's what it is. A lot of folks have a significant reduction in injecting, and sometimes they transition to oral consumption as well. So that can reduce the health outcomes of injecting their substances. A lot of folks see a significant reduction in illegal activities. They have more choice in type of work because they don't need to engage in illegal activity, perhaps to get money for their substances as they were previously. They're starting to have better relationships with non-judgmental healthcare providers. So we try to provide wraparound support for our clients and have a better relationship with healthcare providers as they previously have had negative experiences. So now they've reported that they have fewer barriers when accessing appropriate care. And then we also have just included a couple quotes from our clients. So someone said that they feel more stabilized medically and mentally instead of consistently having to be sick and having to run out and boost things or get money because I am in withdrawal. My withdrawal is managed and I always have a buffer. I really appreciated it because it helps with my mental and lifestyle stability. Someone else said that Safer Supply has saved me from going back to street supply and has prevented me from going under or overdosing. And they're still able to work. They haven't used any fentanyl or heroin in the last 3 months. And finally, our last quote is that someone said that their daily stress levels have gone way down because of the SOS program. They're not committing crime, so their risk of incarceration is gone and they are eating properly now.
Okay, so looking at this team's specific stats over the last 6-month period of time, so from April 1st, 2022 to September 30th, 2022, we are currently serving 23 clients, meaning that 23 clients are currently receiving Safe Supply prescriptions. In the outreach work that the team does, we have seen 200 non-SOS clients that were served through outreach, including harm reduction supplies and education, referrals, meal support, crisis and counseling, and also acute primary care. We hosted 15 drop-in style group sessions that occurred with alternating arts-based activities one week, and then having the following week be a psychoeducation and alternating them in that way. We did one social outing actually across the deck, SOS, so the Downtown East Collaborative, to the Ripley's Aquarium. We did 9 sessions plus a completion ceremony for our Indigenous female identified clients to make their regalia, and the program is called the Northern Feathers, and that was also supported by Wanda Whitebird, one of our local elders. And the total number of direct encounters for the whole team was 713 in the 6-month period of time, and the total number of indirect encounters was 427. There was 152 encounters for informal counseling and 16 crisis counseling encounters in total. And I think that is the end of our presentation. So thank you for having us.
Thank you to the Riverdale Community Health Center for being here, presenting and sharing your experience with us. We appreciate it. Next, we're going to be, I can see that people have put questions in the Q&A chat. If you could continue to do that, because following the next presentation, we will be going through, we'll have a period of questions and answers. So if you could pop all of your questions in the Q&A chat now and through the next presentation, it'd be great. And there's also going to be launching a poll. It helps with stats and funding to allow these to continue. So if you could just, it'll take a minute of your time and we'll continue with the presentations. So the poll will be launched. And our final presenters we have today is Len Hughes and Brandy Tapp from the London InterCommunity Health Center's home team. So Len and Brandy, you can start. Thank you.
Thank you so much. I just wanted to thank you all for being here and for inviting Brandy and I to participate. So I'm Len Hughes. I'm the Integrated Health Manager here at the London InterCommunity Health Center. And Brandy, I will let you introduce yourself as I try and figure out how to share my screen.
Thanks, Len. and good luck. I'm Brandy Tapp. I'm a nurse practitioner at London InterCommunity Health Center. I work in our clinic, and I'm also the clinical lead for our health outreach mobile engagement or home program, which we're going to be talking about today.
Yeah. So Brandy, if you want to just tell a joke while I'm fine.
Len, if you would like.
I'm not a very funny human, Len.
No, I have it here. Just give me 1 second and I'll bring it up. I will, promise you.
Len, okay. I can pull it up probably.
I have faith in you.
Thank you, Rebecca. You're
okay.
Just amazing. Thank you so much.
Just give me a second while I do that. Len, you tell us a joke.
Yes.
Actually, I thought for our presentation today, I know that we've presented on our home program for the community of practice previously. So I wanted to give a brief refresher on the home program, and then I'll let Brandy slide in and talk more about how we serve many of the 300 rostered SOS patients that we have here in London. And I must say that both Brandy and Andrea Serrata do amazing work for us here at the health center. And I'm just honored to be able to support a team like we have here with care facilitators, outreach workers, administrative folks. It's an amazing team to work for. I am amazed every day by the work that each of these wonderful people does in caring for folks in our community. So the home program, or health outreach mobile engagement, is
Len, we lost you there.
Len, I think you hit your mute button. There
we go. So the home program.
Oh, it happened again, Len.
Yeah, it says the host is muting me. So the home program sort of reimagines healthcare for people deprived of housing. Next slide. We provide, so the home program is made up of actually 5 agencies. We provide a multidisciplinary, multi-sectoral mobile approach to healthcare for those who have barriers to care and who are living unsheltered in our community. It's a partnership between us here at the London InterCommunity Health Center, CMHA, Thames Valley Addiction and Mental Health Services, the London Cares Homeless Response Team, Middlesex London Paramedic Service, and the Regional HIV/AIDS Connection. Next slide. So the aim is to engage individuals who face barriers to accessing traditional models of care and to develop service provider capacity to overcome systemic barriers in providing harm reduction, of which SOS is a huge part, and stabilizing healthcare, and of course, comprehensive care and social services. As we all know, the pandemic just really exacerbated the current opioid crisis, and it hit the community in ways we couldn't have imagined. Restrictions began to happen in terms of services available to people facing barriers. And we thought, what can we do to reduce some of those barriers and re-engage with those folks who are lacking those critical supports? We know coming out of the pandemic that homelessness is increasing, that the healthcare system's under immense pressure, and that the folks we serve that are living on the streets are a lot of times just without access to basic supports. Next slide, please. So we said, look, what if instead of talking about hard to reach patients, what if we started talking about how it is that people experience hard to reach doctors or hard to reach services? Right? Or a system that has attitudes of stigma and oppression towards the population that we're serving. Next slide. So we operate on a couple of different tenets, and that is that we feel that the people who use substances are the experts in their lives. We wanted to reduce barriers or have no barrier care. We operate exclusively or inclusively through a harm reduction lens. And it's really participant-centered and participant-led care delivery, and it's non-punitive. We work and surround people who have goals in their lives. We are not making any suggestions to them about what they should be or shouldn't be doing, but rather are present in their lives to walk beside them and provide them the supports that they require. Next slide. So we provide medical care, triage, assessment, episodic care, prescribing, wound care, flu shots, infections, treatments. We have an outreach team that works alongside the clinical team to provide harm reduction support, equipment, supplies, information, education. We really do a lot of relationship building and engagement. We do infectious disease testing, both Hep C and HIV. And we do we have a systems navigator assigned to the home program. So we do a lot of systems, healthcare system navigation, linkages, referrals, accompaniment for clients to support them accessing appointments. And we try and support, and we're building relationships with local hospitals to support our folks accessing and staying in hospital with the medications they require if they need to be in hospital. Next slide. So some of the other things, social service systems navigation, we do assistance with forms, ID, housing, income supports, provision of basic needs, food, in the moment, hygiene products, clothing, again, referrals in real time as needed to agencies or community partner services. We also do peer support and referrals to recovery community if that's what people are interested in doing. And next slide. So the way we're operating currently is we have a team available 5 days a week. 2 days a week, we have folks who will be out on a bus. It's a 24-foot bus that we have just had delivered. We'll have a prescriber, usually Brandy, along with a couple of paramedics, a nurse, some systems nav, a couple of outreach workers who are on site and then fan out to find folks in community. And then 3 days a week, we have a very nimble and responsive team of nurses and paramedics who can do follow-ups, visit folks in encampments, meeting them where they're at to provide health care, wound care, that kind of thing. It's a mobile service. We're trying to be as responsive as possible, given the nature of the current homelessness crisis. We have a couple of fixed locations where we tend to send the bus, but as we work towards trying to stabilize folks who are still without housing and without shelter, we're trying to be a lot more responsive with input from our community partners in order to deliver services where they're most needed, where the encampments are. Next slide. Brandy, I'll let you take over here. Thanks, everybody.
Thank you. So looking at home in terms of how we provide safer supply. So to start, our bus is a fully outfitted medical clinic on wheels. So anything that we do in the clinic, I can do on the bus. So we offer full wraparound primary care via home, and we have added to that safer supply. So because our program was designed to reach and engage with folks who are unhoused or tenuously housed and have limited access or no access at all to healthcare, and that's for myriad reasons, as I'm sure you're aware. By having an opportunity to provide care to that community, we've also been given the ability to provide safer supply to folks who live rough, are unable to access the larger healthcare system, and would otherwise not attend a brick and mortar clinic. So we've put a lot of work and time over the last 35 years in making our clinic accessible, but ultimately at the end of the day, sometimes no matter what we do, a brick and mortar clinic is just not psychologically, emotionally, or physically accessible for some of our community members. The next slide, please. Oh, just went dark. Can everybody? Oh, it's back, sorry. Via home, our Safer Supply participants are distinct from our clinic participants. So we have Safer Supply participants who come to the clinic for care, and then we have Safer Supply participants who come to our bus for care. And many of those differences are directly related to lack of access to meaningful healthcare. So some of the differences that we're seeing is that the majority of the folks who attend home have minimal or no community level supports. So a lot of folks have no engagement whatsoever with any level of support in the community, from outreach workers to mental health supports, housing supports, or even any kind of financial support, including OW and ODSP. We're seeing significantly more untreated or undiagnosed physical and mental health conditions, which, as you can imagine, are very problematic for our patients. Increased illness and injury related to malnutrition, exposure, assault, and lack of access to clean water, and decreased access to safe and clean gear because due to some bylaw concerns in the City of London, a lot of folks who live rough are having to move further and further away from the downtown core, and minimal previous interactions with safe healthcare providers and pharmacies. Next slide, please. Thank you. So our approach to providing safer supply via our mobile clinic remains very similar to the approach that we take in our brick and mortar clinic. So we still aim for weekly or twice weekly appointments with no concrete appointment time. Rather, folks are welcome at any point during our 6-hour home clinic. We aim for 6 hours, sometimes a bit more than that. Because our bus is a fully stocked medical clinic that lets us provide wraparound primary care services, we can offer, in addition to Safer Supply, just like we do in the clinic, full medical care, and that includes lab work, minor procedures, preventative care such as pap smears, ordering mammograms, referrals. Our medical outreach team, which provides street level care Monday, Wednesday, Friday, and that consists of RNs and paramedics, are able to connect with our home patients requiring additional supports on the days that our bus isn't operating. The next slide, please. So we provide Safer Supply via health outreach mobile engagement through a client-centered, team-based, and comprehensive approach. We follow the same principles, guidelines, and protocols as our clinic-based program. And we're absolutely seeing the same positive patient health outcomes and psychosocial impacts, such as reduced risk of overdose, poisoning from a toxic street supply, infectious disease transmission, incarceration, and death. We just have some quotes from some of the folks that receive care via the bus. The next slide, please. So we recently released our statistics, our record keeping for the period of January 11th, 2021 to January 10th, 2022. So in that 12-month period, the home program saw 1,059 unique patients. 71% of those folks came once and 29% accessed care 2 or more times. 1,175 non-essential emergency room visits were potentially prevented. And then 780 chronic illness care visits were conducted. The next slide, please. And to add on to that, just some numbers around infectious disease care, prenatal visits, and by emergency medical interventions, it's actually what we mean by that is CPR or resuscitative interventions. So the nice part about the team we've put together for home is that we have a mix of paramedics. We have 2 full-time paramedics, 4 part-time. There's always 1 registered nurse on the bus, a systems navigator, and myself. So we have a real mix of backgrounds, experience, and skills, which I think is really beneficial to the program. And all 12 of those overdose responses did have a positive outcome. I think this year we're closer for the overdose response number. We've actually surpassed 30, unfortunately. The next slide, please. So for the same 12-month time period, client feedback survey respondents reported also what I see as positive numbers. 100% find it easier to access care, feel comfortable accessing care, would recommend, and have experienced improved well-being. The next slide, please. You can access our home webpage and any other questions you may have. I'm really excited when I get to talk about health outreach mobile engagement, because I think it's a really revolutionary way of providing care, and it's proven to be quite successful and proven to be really beneficial for our community, which is fantastic. Thank you.
Thanks, Brandy. Just wanted to, so we have approximately 300 rostered patients on our safer opiate supply program. And we don't limit access for our safer opiate supply patients. They can access us here in person at the clinic, or if it's better for them and the bus is closer to where they are at in community, they're welcome to visit the bus as well. So there's no distinction or limit on where they can obtain their safer opioid supply prescriptions. Thanks. Thank you, Brandy.
Thanks, Len.
Thank you, Len and Brandy, for your presentation. It really makes me want to see the bus, to be honest. I wish we were in person.
Oh, it's pretty wonderful. You're welcome to come see it at any time.
I want to go for the tour. So we're just going to go into questions. If everybody could pop their questions into the Q&A box. And if somebody had the best person for your team, I guess, can answer the questions. I'm going to start with there was 2 questions that are quite similar. The first one is, how many peers or people with lived or living experience are employed with your programs? And like the follow-up question to that is, and your thoughts, if they're not already involved, your thoughts about adding a peer support worker directly to your teams. So this was directed to everyone. So I was wondering if we can start with Parkdale Queen West Community Health Center.
Sure, I can touch on that. So right now we're a very, very small team. It's actually just the 4 of us on the mobile team, and that is funding related. But while we don't have peers on the mobile team directly, we collaborate super closely with the launch, used to be known as MOVID harm reduction team, which is a collaboration between Parkdale Queen West and the neighborhood group, who employ a bunch of peers. And most of our clients are supported through this extended team. Hope that answers that.
It does, thank you. What about South Riverdale Community Health Center?
I think we don't know who should answer that. I mean, I think we did mention that lived experience is something that's very valued in our group. I'm not sure if we actually have numbers on how many people identify as having lived experience, but I know it is something that is in our job interview. And I will personally say that I do have lived experience. I'm very open about that. But yeah, I'm not sure if anybody else wants to speak to this, if Jolene wants to say anything.
Yeah, I mean, I definitely don't want to out anybody, and I think the whole sort of context around having someone that identified as a peer was something that we wanted to move away from, because many of our staff come with either lived or living experience, and that's something that we look at across the board, and what does that bring to the table. I'm seeing the question about dual of lived and therapy poses a problem around boundaries. So, I mean, Adrienne, I don't know if you want to answer that.
Yeah, I mean, for me, I would say I bring my lived experience into everything I do. I don't actively talk about my lived experience a lot with my clients unless it, and like anything, like sometimes there's appropriate self-disclosure, but it isn't something that I would be like going out of my way to disclose unless it was appropriate. But I do think it certainly informs the way I engage with people and the way I work with the people. You know, just because I remember those kinds of experiences from primarily my past.
Thanks, Adriana, for sharing that and being open to sharing that. Much appreciated. Len, I think you wanted to answer this question as well.
Yeah, so much like some of the other presenters, I've got lived experience as well, and I know that there's a percentage of individuals who are on our team with lived experience. I'd also like to mention there are program participants who help us with a harm reduction kit preparation, and we also have a peer advisory council that that meets monthly to advise the program. So yeah, lots of lived experience.
Thank you, Len. The next question is for the South Riverdale CHC. Does your mobile program have a catchment area? And then let's start with that one.
I can talk a little bit about this. So our program is serving clients east of the main site. So our site, the main site is at Queen and Carlaw, so just east of there. Our main clinic that we operate out of is at Danforth and Greenwood. So essentially all of that East York Scarborough area moving into East Scarborough. Our furthest like outreach drop-in clinic will be at Lawrence and Morningside. Yes, I would say like the East Scarborough.
Thank you. And then from the same individual, for the Parkdale CHC, what is your nearest drop-in location for the North Toronto region, like Young Eglinton, or would you travel to the patient's home?
I can answer that a little bit. We are mobile, so we do go to where our residents live, and right now that is in the shelter system. So we don't necessarily do drop-in sessions. We do intakes and onboard clients formally, and once they're rostered to us, we see them on a weekly or more basis, either in person or through phone calls, and we see our clients in the shelter system. So whether that's shelter hotels or respite centers.
Perfect, thank you. We also have several questions regarding medication. I'm just gonna list the two of them so that people can understand what's being asked. So the one question is, what specific OAT medications are utilized in your safer supply program? And the follow-up question to that is, are fentanyl patches included in the safe supply as they are in BC? And I don't know who would like to answer that first.
I can talk about South Riverdale and the mobile team. So
You've been muted, Naima.
You're muted.
Oh, how's that? Is that okay? Yeah, so the medications we use on the mobile team are slow release oral morphine, so Cadian, and then Dilaudid, the 8 milligram tablets, as the one that people can. So, I mean, people go to the pharmacy and they get the Cadian that they take at the pharmacy, and then they go home with the Dilaudid, which they can take as needed through whatever route that they want to use it with through, and then they can use that throughout the day. And then some people are also on methadone. So generally people are on a long-acting medication, either methadone or Cadian or sometimes both, and then also a short-acting. That's yeah, those are my clients. I'm not sure if maybe another mobile team wants to talk about their meds.
I can also answer that. So at London InterCommunity, we use a pretty wide variety. Dilaudid and Cadian, as were mentioned, as well as just about all prescription opioids that are covered by ODB. We do use fentanyl patches if that's what the patient feels would work best for them. Suboxone, methadone, and also methadone safer supply, methamphetamine safer supply. So Ritalin and other stimulants.
Thanks, Brandy. And is anybody from Parkdale, Queen West, able to answer that question?
Hi there. For Parkdale Queen West, I would say it's very similar to South Riverdale in terms of we do a backbone, which is like a long-acting opioid of usually Cadian or methadone per our client's preference, and then a short-acting, which is usually Dilaudid 8 milligram formulations. Currently, we do not provide fentanyl patches as that's been sort of phased out of our program. There's a few clients with our fixed site who were grandfathered in from a few years ago who are still on fentanyl patches, but we do not provide that currently to new clients.
Thank you. Next question is around what is the maximum capacity for Parkdale Queen West? And they were just talking about how it'd be great to look at a standard referral pathway for all shelter operators and hosting some info sessions for them. They work for the shelter support and housing system, and they thought that would be helpful, just putting that there. But they did want to know what your maximum capacity was at Parkdale Queen West.
So our maximum capacity, we're aiming for about 60 clients. So right now we have about 50 clients. Unfortunately, our referrals are closed at the moment because of the Novotel closure. There's been an upheaval of most of our clients from that site. So we put just a break on and accepting any new referrals at this time. But I think that would be great if you would reach out to us and we can talk about the referral pathway a little bit more.
Perfect, thank you. So the next couple of questions I think are for Len and Brandy. So paramedics on the bus for home, are they in partnership with EMS or like paid or volunteer?
Sorry, Brandy. Yeah, so we're in partnership with Middlesex London Paramedic Service. They're paid employees of Middlesex London Paramedic Service, but they work for the home program. So when it comes to the home program, actually, most of the agencies we're partnered with provide resources and like human resources to the project in kind. But we do pay for the paramedics, and they're on a salary through the London Middlesex Paramedic Service, but work for the home program.
And if I could just add, we have 6 total paramedics, 2 full-time, 4 part-time. They were all very carefully chosen and went through a fairly extensive training program that we developed to introduce them to not only primary care, but the way we provide primary care.
Perfect, thank you. The next question is directed specifically to the trauma support workers. Can you elaborate on some of the best practices you have used with the most success? They understand it's very individual and person-centered, but is there a specific crisis tool or area to start that has been the most successful?
Nikki, do you want to go first or do you want me to say anything?
You can go ahead, Adriana. Sorry, just having some problem with my volume.
Okay. I mean, I can't really think of anything specifically. I mean, the main thing that I would say is the most important is just around really focusing on safety and stabilization, and really just, I think just really recognizing that our clients often they're experiencing trauma or an experience that maybe they don't even see it as trauma, but it's overwhelming their capacity to cope in the moment. So just anything we can do in terms of like being a calm, grounded presence, I think is helpful. Also just doing like sort of like basic sort of grounding techniques. So I do find some people, if you're too heavy into the grounding, they're like, what the heck are you doing? You have to, it is very individualized, as the person asking the question said, and we kind of we have to be very flexible and just kind of adapt and see where the client is at, and then just kind of like go with the flow of that. So sometimes it's about being like super directive. Other times it's really about just like listening, and maybe reframing a few things and developing a bit of a safety plan. So this is just I hope I'm answering the question all right. Nikki, do you have anything to add?
Yeah, I mean, I just want to echo your point, Adriana, that I think every client is different. So what works for some clients may not work for others. And then what works for one client one week may not work for the same client the next week. So using strategies like motivational interviewing, like readiness for change, and then all the way to like just supportive listening, depending on what's going on for the person, has been effective for me.
Thank you both for sharing that. The next question's wondering, just for follow-up in the community with participants, wondering about experiences using pharmacies for titration, nursing-led follow-up with high transient, low engagement, and the implications for UDS brackets as per the program requirements, while in the community for follow-up.
I could speak to this a little bit. We have encountered a few of our clients who have a really, just have a lot going on in their lives, and so coming to these appointments is really hard. And so we try, really, it's been very individualized. So we try to kind of sit together as a team and then talk to the client about what might work. Like most recently, we were able to connect with a client who we hadn't seen in like several weeks, and we I sat with her and like to ask her about, what is there anything specific about the space or the type of meetings or anything we can do to make her more comfortable, right? And so she at that point was like, yeah, it's this clinical environment that makes me really anxious. And so then we did some brainstorming about what would work better. And so we were planning on meeting her at coffee shops, for example, going forward. Question about UDSs. I think like we don't do UDSs I feel like it's very random. Like when people come, because we're mobile and because we're at different places and on different days of the week, we don't see clients that often anyways. So we'll see them like we might do multiple appointments, but maybe one of them one week it's in person and the other week it's over the phone or something like that. So we'll kind of do UDSs as available, like when the client does come in person, or they're able to meet us at a location with a bathroom, then we'll do the UDS. And or if they want to do it at any point, if they're curious about what they might have in their urine. And so we keep it pretty like open-ended. I feel like it's not structured or strict. And then there was something else, something about pharmacies. I forgot what the part about pharmacies was.
I think using pharmacies for titration and nursing-led follow-ups.
Oh yeah. So yeah, we do for our clinic days, it's pretty flexible in terms of RN and NP engagement and who does the follow-up appointment, especially for clients who are stable in the sense where they don't have other medical things going on. Our team is very nursing led with our follow-ups, and it's worked pretty well for us, especially when we have to go to different locations on different days. And yeah, for pharmacy, I mean, I'm not sure the pharmacies, we have had some, I think it's helpful that we have this pharmacy consulting pharmacist, because we have gotten some tips about how to communicate with pharmacies and like what kind of documentation to give them and things like that. So yeah, it's a continuing, honestly, it's like an ongoing game of like finding pharmacies in the community in the East End and like figuring out what will work best for different pharmacies.
Thank you. Does anybody else want to answer that from the other sites, or are we good to move on? Just wanted to give the option out there. The next question is, what advice might you have for communities that are struggling to get support from municipalities for safer supply programs? Any political advocacy advice or examples of activism that has led to the establishment of your programs?
So in London, I will say that Dr. Sereda has been prescribing now for, I think, just over 6 years. And speaking from our experience here, she is the tip of the spear. She is magnificent at advocacy with community partners, with community associations, with the City of London itself. And she does not come out of those discussions unscathed. Perseverance. Early on, when we began this type of care for folks, we had a visit from the CPSO. We explained our position. We talked about harm reduction and how this was an amazing piece of harm reduction for people. And we were given the green light from the CPSO. We're told to carry on. And from then on, a lot of our leadership team and our directors are in constant engagement with various community associations, various council members here on London City Council. And slowly but surely, through the perseverance and tenacity of our team, we are changing hearts and minds. And so the advice I would give to any community that would like to start a safe supply program would be to carry on, keep carrying the torch. Honestly, it's a much needed source of healthcare for many in our communities to end the suffering and reduce the risk of opioid poisonings from the contaminated street drug supply. So keep on keeping on. That's my advice.
Thanks, Len. Anybody from the other sites want to talk about the advocacy to get your program up and running? No? Sorry, we can move on to one final question. Does the home bus or the CRCHC program offer hepatitis C HIV testing or treatment prescribing on the actual bus, as opposed to referral in the main health center?
And so, sorry, go ahead, Brandy.
Yes, we do. That's all I was going to say.
Yeah.
So the LIHC has a hepatitis C care team, as well as an HIV care team that exist within our brick and mortar clinic. So we can make referrals to them in the clinic, but they also join us in community often. And yes, we do point of care and laboratory-based testing on the bus.
Thank you. And what about the South Riverdale Community Health Center? I think that was asked to both sites.
I can answer this. So I think the difference, and this is something that I was thinking about as we were presenting, but we have a van that we have access to part-time, but we don't provide services on the van per se in the same way that it sounds like London Intercity Family Health is providing care specifically on a vehicle. But when the team goes out, there is options for people to have HIV and Hep C testing, and if they want to be treated in community, that's an option. If they want to be referred back to the 955 clinic to the Hep C team, that's an option as well. And I think one of the incentivizations of people wanting to come to 955 for their Hep C treatment is that they have a program that is an incentivized program, and it connects them to a group as well while they're going through their treatment. So I feel like South Riverdale's Hep C program is pretty well known in community, and that usually is where people do want to access. But it's not exclusive. It's not the only way that they can get Hep C treatment.
Thank you. Time has flown and there's only 4 minutes left. So I'm going to pass it over to Rebecca for some closing comments.
Thanks so much, Chris. And thanks to everyone here. There are a lot of questions that people have asked that we weren't able to get to today's in today's webinar. Some of them are on topics that we're hoping to address in the near future. For example, continuity of care for a safer supply across corrections and hospitals, and then also questions about fentanyl patch programs and fentanyl and the use of fentanyl and safer supply programs in general. So please stay tuned for those. I'm also really happy that the presenters here today have shared contact information. So we will be posting the video of this webinar and resources, including slides and such, with the permission of our presenters, of course, up on our website. Yeah, that's another space. For those of you who are not members of the community of practice, I do encourage you to join, and that gives you access to our Google group where we do have conversations between our members, as well as our newsletter and access to some of our members-only resources. So to join the community of practice, you go to our website, and I'm certain that one of my trustee colleagues will be posting that in the chat now. Yes, thank you very much to all of you who have attended today. And my big sincere thanks to our presenters today who took time out of their busy work days and to put their presentations together, to be here with you today, to share about the work that they're doing. What an amazing group of people. Thank you very, very much. Really grateful for you. Also very grateful to Coop Largo for the French translation services today. Thank you very much.